Dr. Karat and Dr. Mazur for all their support over the past year and making this project possible. Okay, so quick overview. Going to talk about the project's purpose, the definition of telehealth, and sort of if it's effective or not. Look at utilization before COVID-19, some of the adoptions, barriers to adoption, and reimbursement challenges. Then I'm going to cover what's changed after COVID-19, look at utilization, and then finish with some of the ongoing challenges and stakeholder considerations. Okay, so jumping right into it. This project's purpose was in general just to develop a better understanding of reimbursement policy and its impact on telehealth utilization and identify areas for opportunity for research in the future. The main deliverable of the project was a white paper that was intended for a general audience, something that I could take back, say, to the clinic that I work at and share it with administrators. So we all have a more foundational understanding of the strategic implications of telehealth policy. Okay, so general in nature and sort of applicable to all stakeholders. So to start this off, I conducted a literature review of PubMed and Scopus. This proved to be a bigger challenge than I anticipated, mainly because of the amount of telehealth research that's going on right now and the amount of publications. So I had to really work to refine my search criteria. And so if you'd like to see my synthesis matrix or the details of my search criteria, reach out to me afterwards. I'd be happy to share that. But that proved to be a big challenge. And also there just wasn't a lot of publications on COVID-19 or post-COVID-19. So it became clear I was going to have to sort of supplement that research. And so to do that, I interviewed currently serving health administrators within North Carolina, Virginia, and Minnesota. These were large health systems. Two of those administrators were regional health, regional clinic administrators, meaning they oversaw multiple clinics and hospitals with a wide range of specialties. And then I supplemented that research looking at sources outside of those databases, so looking at CMS policy directly, what states have implemented and sort of ongoing legislation, and then sources like through Medscape and like Wall Street Journal, New York Times, that type of thing. Okay, so what is the definition of telehealth? I have a general sort of definition that I utilized for the purpose of this project. And this is sort of the most commonly understood definition, which is plainly the remote delivery of healthcare to a patient through technology. The definition of telehealth has changed dramatically over the years because of developing technologies. There are also much more technical definitions, especially if you look state by state in terms of how Medicaid defines it and the state defines it, because it was directly tied to reimbursement. So they would utilize that definition as a legal justification for including or excluding certain types of care. So main thing is here, there are lots of definitions. I took this sort of most general definition and is often used today with the term telemedicine. And there are three key categories that I wanted to highlight here, and I'll use these throughout the presentation. The first is synchronous. This refers to live communication via video chat or telephone. It's probably the most commonly understood form of telehealth when people first hear the term. The second is asynchronous, which is the exchange of information when not connected at the same time. This is also referred to as store and forward. This is for things like telederm, where or teleradiology, where you may send an image to your provider or send a test to your provider, and then they'll review it upon receiving it, so fairly common. And then sort of the most complex and evolving category is remote patient monitoring, RPM. This is where you're collecting and transferring data specifically for tracking and monitoring. And the key thing here is it does not require direct intervention from the provider. So you may have something like, say, a blood pressure machine that would be pulling a test twice a day and then keeping track of that, potentially even writing it back into EHR, but it's not going to require any intervention unless something abnormal pops up. And at that point, it might not even require intervention from a provider and may just provide alerts to the patient directly. But that's a key differentiating factor among those categories. Okay, so for the efficacy of telehealth, jumping into this research, it became very clear that there's a consensus of its effectiveness. This is a quote directly from one of the articles that I pulled. And the general consensus is telehealth has been proven to improve access to care, decrease costs, and has patient satisfaction that is either equal to or greater than face-to-face visits. Now, there is a huge caveat with this in that this research varies heavily by the specialty of healthcare and technology that you're utilizing. So the early sort of definitive studies were related to chronic care management, things like diabetes and cancer, and things like telederm, right? So if you really have to consider it by specialty, but the evidence clearly supports its effectiveness. And the CDC and CMS also confirms this consensus, citing research prior to COVID-19. And just to kind of highlight the growing amount of research on this topic, this is just a PubMed search of telehealth. You can see that publications have been steadily growing. And of the time frame that I looked at, 2016 to 2020, there was over 16,000 publications. So a lot of research on this and a lot of data supporting the effectiveness of telehealth. So that leads one to wonder, have we seen this spike in utilization and adoption of telehealth? And the reality is we just haven't. Despite all of this evidence and interest, there hasn't been big adoption. And in 2013, only 50% of health systems even reporting having some form of telehealth. And not only is just the research growing, but consumer interest and demands have also been rising significantly over that time. This chart is from a study in Minnesota where they looked at telehealth encounters across the different payers, and you can see a steady increase. However, as that relates to the overall healthcare marketplace and appointments offered, it's just a very small amount. And so, for example, the health administrator I spoke with in Minnesota, leading right up to COVID-19, this is in 2020, telehealth visits only accounted for 1% of their overall visits. So still a very, very small amount of overall market share, despite just sort of this wave of interest and research supporting its utilization. And as I was digging into this, it really felt like there was just this gigantic wave of research and interest supporting the adoption. So, of course, that leads one to wonder, what are the key barriers? And there were several good studies that highlighted them. So I'm going to run through some of those barriers right now. Most of these came from annual surveys that went out to health systems administrators and asked them what were the biggest barriers to adoption. And these are not listed here in any specific order, but I'm just going to kind of run through them. First of which is security. That is a big challenge, or HIPAA requirements. There's also consent challenges and just technological requirements that are a challenge. 2, costs for adoption, which are obviously related to reimbursement, but there are significant challenges with training as well. Just cultural norms. A lot of physicians are still hesitant to adopt telehealth, and patients as well. Credentialing, you could only utilize telehealth within an individual state. This was a big challenge for sort of direct to consumer telehealth providers. And then there were technical issues cited outside of broadband access or high-speed internet access. And broadband access is still a challenge even for some health systems. If you think of critical access facilities or facilities that may not be as well established as others. And then partners, whether you're talking about provider groups or insurance providers willing to reimbursement. And then, of course, there are additional regulations or policies surrounding it, but overwhelmingly, reimbursement was cited as the primary reason for not adopting or utilizing telehealth to a greater extent. But it is really important to note that even if you were to give health systems and providers all this money to start doing telehealth, there are significant barriers that need to be noted and overcome before you can start rolling it out. Okay, so looking at reimbursement specifically, kind of synthesized the challenges I saw into 4 main categories. And one thing I want to caveat with this before I go through these is um, the health insurance marketplace and what gets reimbursed at what rate is largely dictated or influenced by Medicare and Medicaid. They sort of set the baseline for reimbursement numbers. So as I go through these, that's kind of the assumption I have of your understanding of the insurance market. Medicaid is at the state level. Medicare is at a federal level. So as you hear me use those terms, that's what I'm referring to. So the first big key challenge is that synchronous care, so that typical care you would understand via video or telephone in replace of your face-to-face is just not getting reimbursed at the same level. And there are additional requirements that come along with that. There are several studies that looked at specific types of telehealth in relation to their face-to-face counterparts, and reimbursement was still significantly lower than those face-to-face encounters. And some states had adopted reimbursement for video synchronous care, but that would only apply to patients that are in rural areas or had other chronic conditions that they essentially had a waiver to be able to get reimbursed fully for that. And that kind of ties into the second one, which was just overall with this project was really enlightening for me, is that the regulations regarding reimbursement varied dramatically by state. There were several really great articles that came across that characterized the different reimbursement policies and their impact on telehealth just at a state level. And then at the federal level, you have multiple organizations that create policy and interpret policy, which make it very difficult for health systems to try to project the growth and reimbursement in general of telehealth. So for instance, at the federal level, not only do you have multiple pieces of legislation working its way through Congress, but you also have organizations like CMS and the FDA, which have significant power to interpret existing policy and create guidelines. And the FDA specifically governs medical devices, which have a big role in what you can utilize for things like with RPM, remote patient monitoring. So there are just a myriad of different regulations that need to be considered when you're trying to plan for reimbursement. And that kind of leads into the next one too. In the research that I looked at, it was a big challenge, very big challenge at first to find research that focused on cost effectiveness and cost structures. This was very discouraging for me at first until I found really good articles on this, which highlighted those challenges as well. And there are some good reasons, which are the fact that new technology is being developed at a rapid pace now, and the application of different technologies, even just the telephone call, varies tremendously by the specialty of care or the service line that you're utilizing it in. And just in general, building cost structures around telehealth is more complicated than your typical brick and mortar evaluations. And so just think of like if you have a provider working from home and they do a telephone consult with a patient. Traditionally, you would include overhead costs from like the facility that they work in and other things like that. But if they're working from home or if it's just a telephone consult, do you incorporate those traditional overhead costs or not? And as you look at more advanced technologies, that gets even more complicated in just how you allocate and extrapolate those different costs. But in general, that was a big challenge. And it kind of leads into the fourth one here, which is I wasn't able to see the utilization of a framework for evaluating telehealth effectiveness, whether you're talking about costs being incorporated to that or not. And this has been addressed by the government. And in 2018, DHHS did fund the development of a framework. But I didn't come across research that had been utilizing that framework, and I wasn't able to find evidence that had been widely adopted. So as you go through these different studies, it's challenging because you really have to dig into what their criteria is for cost effectiveness or just effectiveness in general. Okay, so jumping into COVID-19, and you'll see these kind of follow through with considerations after COVID-19. So some big, huge, sweeping changes happened with the onset of COVID-19, the first of which was CMS approved 80 new telehealth service lines. And so that means 80 specific codes that were before limited to face-to-face encounters now had telehealth approved. They advertise that they are reimbursing telephone visits and video visits at the same as face-to-face. However, there's an asterisk there because the interviews that I conducted and from the research that I found, there is still problems with telephone visits not getting reimbursed at the same level. And that's because of the different types of visits and coding structures around those. So it's not, you can't simply just say they're going to be getting reimbursed across the board, similar to face-to-face. Another big one was relaxed HIPAA enforcement. So if you have an encounter, you can, or if you have an encounter with your provider, they can meet with you over Zoom or Skype. Prior to COVID, that would not have been allowed because of the HIPAA security requirements tied to that telehealth technology. So right now, it is a good faith enforcement, so long as the health system makes a good faith effort to maintain the security of your data. They will not enforce penalties. Another big one was obviously you can do your telehealth in-home versus a designated area. That kind of refers back to there being unique regulations for where you can get your telehealth services if you're in a rural location, or even some types of asynchronous care that was only at a designated facility. Providers can practice across state lines. Again, that was a big one for direct-to-consumer telehealth companies. And then care can be provided to new and established patients. That's a big challenge and concern for providers because they were going to want to see your, as a patient, health record before they start seeing you over the phone. And then lastly, they allowed private insurers to adjust their plans to increase or adjust reimbursement for telehealth outside of their normal annual policy changing dates. But of the research that I looked at and talking with the administrators, the overwhelming consensus was that these organizations even attempted to utilize telehealth because of the enhanced reimbursement and changes to those policies. One example, was a dermatology clinic where they were going to furlough all their employees and temporarily close the clinic until things turned around. But once they found out about the opportunity to get reimbursement with the COVID-19 changes, they decided to adopt different telehealth technologies and try to make that work. Okay, so what happened after all this? Of course, as you would suspect, telehealth utilization jumped dramatically. And to kind of put this in perspective here, on the right, this was from New York, a study shortly after COVID hit. Prior to COVID, this was before March, they had on average 500 telehealth encounters, and that jumped all the way to 83,000 immediately after March. So that's pretty staggering. McKinsey & Company, the large consulting firm, estimated that on average, health systems increased telehealth utilization between 50 and 175 times what they were doing previously. This also aligns with the interviews I conducted in Minnesota. That system had only 1% of their total visits prior to COVID related to telehealth. After this, immediately following these changes, that jumped all the way to 80%. And McKinsey & Company also highlighted some interesting research showing changing perspectives on the provider and consumer level of their willingness to use telehealth. And they project that 20% of all outpatient care could be virtualized or transitioned to telehealth care with an estimated value of $250 billion. So bottom line, you saw a huge jump, a huge transition, and But the reality is the sustainability of those changes is still very much in question. And so looking at some of the ongoing challenges, the first of which is the policy changes after COVID-19 are only temporary, and they are tied to the national emergency status. So literally, if the national emergency ended tomorrow, theoretically, all of these policies would then go away and revert back to the way they were before. And most health systems and most of the research I cited, they're all planning for the changes directly related to reimbursement likely to stay in place. But that is a huge challenge. If we're going to continue to see the sustainability and reach that 20% or $250 billion mark, you're going to have to see those temporary measures enacted permanently. Additionally, as I kind of touched on earlier, even though we had these changes after COVID-19, there are still some significant challenges, the first of which is telephone visits not getting reimbursed at the same level as face-to-face. That's a big challenge because often these providers may be planning to do a video consult, but because of technical challenges or whatever, they have to divert to a telephone. And if they're not getting reimbursed at the same level, you can't really strategically plan for that and build your schedules and templates around having video conferencing if it's not always going to follow through. And there's still a big problem with asynchronous reimbursement. Several studies cited just even text messages and secure messaging, which has been around for a while. There still really isn't effective reimbursement policy regarding those, despite their increased adoption. And that's been a challenge for a while. And then, as I hit on earlier, there's still a lack of framework for evaluating these new telehealth services. And this is especially important for new technologies that are asynchronous and RPM because they are more complex in nature. So to sustain and to continue to see growth and reach that 20% and $250 billion mark, you're really going to have to see some significant changes to sustain that. And I want to highlight too that health systems right now are dealing with some significant financial challenges. One report estimated that the industry as a whole is using $50 billion per month. And of the administrators that I spoke with, they echoed this challenge as well. In Minnesota, they just announced last week that they are closing 5 clinics. And the other 2 administrators I spoke with, they were starting to furlough, lay off, and close clinics as well. So you're going to see increased financial pressures within these health systems. And so without effective reimbursement policy, I just don't think you're going to see sustained adoption of telehealth or sustained utilization of telehealth going forward. And I think that is the big takeaway from this presentation in general. And so I'm going to kind of tie this all together with a stakeholder analysis, just kind of running through some of the major questions that exist for each of these going forward. And I think that the biggest challenge lies with policymakers at the state level. Is your state, how are they managing their reimbursement policy? Are they comparing to other states? Are they looking at best practices? At the federal level, as I mentioned earlier, there are significant challenges there. And I mean, just one big question is, should we consider a sort of bailout or an enhanced reimbursement telehealth policy to get through COVID, the COVID-19 emergency because of the financial challenges that these health systems are dealing with? And then at the payer and insurance provider level, you have similar challenges. Research that I just saw stated that insurance providers are having increased profits but reduced revenue overall since COVID. So theoretically, they have some leeway in trying to find new frameworks and evaluations with health systems to try to influence the greater adoption of telehealth. And so at the health system level, I really think they need to be looking at what service lines are best suited for telehealth and which are going to be financially viable. Make sure you're partnering with payers and lawmakers to ensure that they understand the value of telehealth in those specific service lines. And then sort of in my wheelhouse, where you're looking at health information technology companies or even departments within health systems, I think the entire sort of driver behind the market as a whole is going to be tied to reimbursement. So as you're trying to plan for strategic acquirements of telehealth technologies, or even if you're considering working for a new telehealth company, there are significant challenges for sustaining that large of a market for telehealth. And, just to kind of drive this home, unless, like a Blue Cross and Blue Shields of North Carolina is going to start paying out or reimbursing and covering telehealth, you're just not going to see the entire market as a whole transition to these type of technologies. Now, there is a big caveat there where you have health systems that serve as their own payer and provider, and organizations like Amazon and Apple actually insure all of their staff and have been getting into the payer side of the business, the provider side of the business. And so organizations like that have a lot more leeway in adopting and implementing new technologies because they're not reliant on Medicaid, Medicare, and other private insurers to reimburse those technologies. And that also includes organizations like the VA and the military health system, where they're not as reliant on reimbursement from Medicare, Medicaid, and private insurers. And kudos to the VA, they have done a lot of great things in relation to telehealth. So that's important to note too, going forward. And from a patient perspective, I think key thing is, do you understand the security and consent requirements that go into it? Are you comfortable with that? And do you have just the infrastructure, the IT capabilities at your house to start utilizing telehealth more frequently? And then lastly, kind of summing this all up, after conducting this research and finishing this project, I think I left with more questions than I had answers, which I took away as a good thing. And there are many different areas, I think, that could use additional research. And from an informatics lens, if I were to go about this, trying to target research going forward, I would look at a specific type of technology in a specific healthcare specialty within a specific state, and look at and utilize a standard framework to evaluate the effectiveness of that telehealth service. So I think that kind of pulls the whole thing together, and that concludes my briefing. Does anybody have any questions?
Hi, this is Lisa Visor. First, thank you for the presentation. I thought it was really interesting. You said that CMS temporarily approved 80 new services. Do you get any sense about whether that's going to continue, for telehealth, past the pandemic, or is there any expiration date on that?
Yeah, so technically right now, if the national emergency ended, if COVID was cured, those temporary policies would cease to exist. Now, the health administrators that I spoke with and the research that I looked at and the sort of legislation that's working its way through, the assumption is those policies, as it relates to reimbursement, are going to be permanently adopted. So that is a good sign. But for instance, the administrator I spoke with in Minnesota, their initial adoption jumped from 1% to 80%, and then the most recent month it went down to 50%, and they're projecting for 30%, planning for 30% because of the variation with how that policy is going to be implemented. But they are planning for those temporary measures to be permanently implemented.
Thank you.
Are there any other questions for David?
Hey, David, this is Lucas Mazur. Can you hear me?
I can.
Yes, thank you for a great presentation. That was really, really great. My question kind of comes down to, as you interviewed and you kind of dove deeply into this subject, what about usability, kind of overall usability of these platforms that physicians are using, and any considerations for patient safety that maybe came across as you were kind of going through the subject?
Well, I was surprised in general to find that that wasn't a big uh, sort of challenge cited. I know that there are just certain things that a provider just can't do over the phone over video. And I think the biggest thing that I found as part of this project was actually related to the fact that they can utilize Zoom and Skype. And I was surprised to find that two of these large health systems were utilizing Zoom, because it is not anticipated that um, that policy is going to be sustained after COVID-19. And so these systems will have to uh, transition to a service that is meeting all the HIPAA security requirements. But in terms of sort of patient safety risk or patient safety concerns that vary heavily by specialty of care and the telehealth intervention being utilized. A lot of the early research pointed to patient satisfaction and provider satisfaction being just as high as that of face-to-face visits, but I can't really speak to research that directly tried to characterize the patient safety risk as it relates to the various specialties of care.
Okay, thank you.
And if anybody would like, like the white paper or synthesis matrix or any of these references, just reach out to me afterwards. I'd be happy to share my experience and my process.
Are there any other questions?
This is Lisa Visor again. I guess my big overall question is what do you think is the direction that things are going? I was interested to hear you say that the people in Minnesota they've seen such a fluctuation in utilization. What was your big picture sense of how telehealth is going to be utilized going forward, if they can get the reimbursement figured out?
Well, this is a great question because I'll do my best to answer it. At the service level prior to digging into this to this extent, there's like a general consensus, I think, that telehealth is having a moment, and there's all these new technologies, and after COVID-19, we saw all this adoption. But the reality is, for these health systems in that big cut of the healthcare marketplace, it's just not it's not penetrating that. And even after these temporary changes have been implemented, it's still not enough, I think, to see the profound transition to a more digitized type of healthcare that a lot of us are envisioning. I think the temporary challenges or temporary policy changes are a good step, but they're still not sufficient to sustain even at a 20% level. So in the past month, the article I looked at, you saw record investments in telehealth technologies, despite the financial situation right now with COVID-19. And I think that's probably a little bit inflated or highly contingent upon federal and state lawmakers drastically reinvesting in how they look at and evaluate how they reimburse these different types of telehealth technologies. Because right now, as it sits, even with these policy changes, I don't think you're going to see sustained 20% or $250 billion annually. So does that answer your question?
Yeah. Do you think there are certain applications where it makes more sense than others? I'm thinking particularly about mental health, where we've seen it seems like we've seen some expansion of services to people who weren't able to access services before, because of telehealth. Yeah, wondering if that will,
Yeah.
help with access going forward.
Great question. And there are definitely service lines or types of care that have definitely shown to be sort of surefire effective. Those are psychiatry, dermatology, and chronic care management. So specifically like diabetes and survivorship for cancer patients. So there are definite, and there's, if you were to sort of break it down by categories, and some of the research tries to do this or highlight those areas that are have demonstrated clear effectiveness, and those were chronic care management, psychiatry, and dermatology. Ironically, came up quite a bit as well. So those three key areas, I would say, I found the most research on.
Thank you.
Well, thank you, Dr. Weiser and Dr. Mazur, for your questions. And if there are no additional questions, I will go ahead and thank David for his great work and great presentation.
All right. Thank you, everyone.